I'm honored to be able to present in front of you. My name is Doro India. I'm a pathologist that specializes in the diagnosis of skin diseases and skin tumors. That's why it's called dermatopathology. And I'm going to try to shed some light on a more hidden part of pathology of melanoma treatment, which is the pathologic examination. So today's goals are going to be to introduce the field of pathology, outline the primary ways in which pathology contributes to the care of melanoma patient, and also discuss the role of second opinion in pathology. So what is pathology? It's a field of medicine that uses laboratory methods to study and diagnose disease. And pathologists that work here are physicians with specialized training that, among other things, are responsible for guiding medical treatment by studying tissue samples and also blood. And pathologists do this by using a variety of laboratory methods that help diagnose melanoma and guide the treatment. This is our faculty, pathology faculty at Roswell Park. And this is the team that specializes in melanoma diagnosis. And this is Dr. Alicia Goldenberg, Dr. Paul Bogner, and myself. I want to acknowledge Dr. Bogner for sharing some of the slides for this presentation. So what is the role of pathology in melanoma diagnosis and treatment? The first and probably one of the more important roles in this diagnosis, as Dr. Para said, it's important to have a pathology exam in order to be able to differentiate between nevus and melanoma, so between benign and malignant. And you've seen images of these pigmented lesions of the skin, and you may have a suspicion clinically that some of these might be melanoma, but often, almost always, the final diagnosis is established by pathology, either benign or malignant. So how do you do this? So what happens, a tissue sample is taken at the time of the examination. It's placed into a container filled with a substance that helps preserve the tissue, which is a fixative, sent to our department of pathology, and in a few days you have a pathology report. So what we're going to do is try to look behind the curtain and see exactly what happens actually in the pathology department to diagnose these lesions. So the piece of tissue is placed in one of these plastic cassettes, and that's put in that tissue processor that you can see on the left here. Let's see if I can, this one. And what happens here, the tissue is infused with paraffin to make it harder. So instead of being soft, it's going to be harder. And you'll see why, because you need to cut it. Taken out of the tissue processor, and we use a mold to actually embed that tissue into paraffin. So you can see here, what the technician is doing is putting into this metal mold the tissue, and then from here you can pour liquid paraffin into this. And ends up that after the paraffin solidifies, you get a block of paraffin that contains the tissue of interest. The next step is to actually section it. So you use this device called a microtome. It's kind of similar to a deli slicer, but much, much more precise. Cut these sections that are 4 or 5 microns thick. To give you an idea how the thickness of this, like the spider net, is about 3 to 8 microns. So it's about the same thickness, and it's much, much thinner than a paper sheet. Those sections are then floated onto a water bath, and you can come, this is a glass slide, you can come underneath and pick them on the slide, and you end up with these glass slides that contain the tissue, very, very thin sections of the tissue. Now, these are transparent, so you can't see anything of them, so you'll need to color them. So we use a stainer. It's pretty much the same as you'd stain, or you dye your clothes, for example. So you put the tissue through various stains. The ones that we use are eosin, which is pink, and hematoxylin, which is purple. So it's going to be a pink-purple color. And then you end up with these slides that are now colored, so you can see what's going on. So the next is one of the most important parts, which is a microscopic examination. So this is performed by a pathologist, who again is a physician with additional training in recognizing different patterns that help diagnose benign or malignant lesions. And he uses a microscope, so you can see the slide displays here, and this will magnify the image, and you can see it on these eyepieces. And then that renders a pathology diagnosis. So that's what one of these pathologists will see under the microscope. This is a picture of the skin magnified 20 times. And you can see up top here, this is the surface, which is the epidermis. That's what you can touch on your skin. This pink thing would be like the dermis, and underneath, this is fat, is the subcutaneous tissue. You can see shades of pink and purple because of this hematoxin and eosin. You can go even higher magnification. This is now 400 times. So now you can see individual cells. This is the surface epidermis, the surface of your skin. This is called stratum corneum. That's why the skin is impermeable. Water doesn't penetrate. And you can see the purple round structures are the nuclei, which contain all the DNA that's needed for cell function and replication. And then the pink stuff around this is the cytoplasm. This is one cell. These are all sort of skin cells, but here and there you can see these are the melanocytes. These are the normal melanocytes we've been discussing. These are, look, uniform and small. These are not malignant. You have the organism, as was discussed before, to protect you from UV exposure from sun. Now, this is how some of these lesions might look like. On the left, you see a benign lesion, which is a nevus. On the right, you see a melanoma. It's a special type of melanoma called nevoid. It's called nevoid because it looks like a nevus. So this illustrates why it is important to look under high magnification. And you can see there are some differences in the density of cells. All these little purple dots are melanocytes. Now there's many, many more melanocytes. And you recognize that there's, you can look at certain patterns and differentiate benign from malignant. These are some of the features we look at the microscope to differentiate a benign lesion versus a malignant lesion. We're not going to get into the details. This is highly specialized, but just to give you an idea of the skill that's needed to do that. This is not a type of melanoma. This is our Dr. Bogner, who does that all the time. So you can see here, these are the melanocytes in the epidermis. So you can see how many more there are here. So you can look at certain patterns and say that this is malignant, and specialized physicians can diagnose that. The second role is to classify a type of melanoma. So melanomas, it's considered to be not even one disease, but several related diseases. And same as you see here, the apples, they're all apples, but some are red, some are yellowish. There's different types of melanoma that you can recognize under the microscope. And it's been discussed, various types, and I'm not going to go into the details, but just show you like an example. This is a lentigo maligna and a superficial spreading melanoma. And they're both melanoma. You can appreciate these dark dots are the nuclei, or the purple dots of the melanocytes. Remember the normal skin, there are only like 2 that you could see. There's like many, many here, and same in this area. So they're both melanoma, but the way the melanocytes are arranged is different. So to the trained eye, you can differentiate that one is lentigo maligna, one is superficial spreading melanoma. The next role is establishing the stage, or helping establish the stage of the melanoma. So what is staging? It's been discussed before. It's a measure of the extent of cancer at a given point in time, usually at the time of diagnosis. And there's 2 components. There's a clinical staging that's done using the clinical parameters. So you can look how far the disease has spread. And there's also a pathologic staging where you need to use a microscope to establish the stage. As we've discussed, staging provides prognostic information and affects treatment planning. So it's important to stage the patients correctly. We discussed that we're using this TNM staging, tumor, stage, lymph node, which is the spread, and then this distant metastasis. And the tumor stage, this is one that you need pathology for it. So this is an example of a melanoma, a nodular melanoma. And you can see this whole circle encompasses the melanoma. You can see a little bit here of the surface epidermis, and this is a large nodule. You can imagine this was be a nodule on your skin, and then there's a bit of epidermis here. So one of the important parameters is measuring the depth, and we do this under the microscope using a specialized eyepiece that can actually measure with it. So in this case, it's 8 millimeters. And you also assess if there is ulceration or not. So ulceration means that the epidermis is gone from the surface. So you can see this area. You can see epidermis here, and then it starts to disappear. So this area is ulcerated. That will mean pathology tumor stage 4B. And you can use these other classifications for T from in situ to T4 based on the depth and the presence or absence of ulceration. You need a microscope to do this. Next is the end stage. You look for metastatic tumor cells, and this could be clinical. If the metastases are big and bulky, you can see them on imaging or even palpate them. But sometimes they're very, very small. This is a histologic image of a lymph node now. You can see this round structure. The purple dots are all lymphocytes, so it's hard to see much. But then if you look under the microscope in a certain area like here, you can detect there's some pigment in these cells. It's still hard to tell. I mean, I can see that maybe this one looks a bit atypical, but I wouldn't necessarily be able to tell if that's a melanocyte or some other cell that has pigment. Luckily, we have special stains. So these are particular stains, different than hematoxin and eosin, that stains only melanocytes. So you can see now all the cells that are basically bluish are not stained, and you can see this large one here has a brown cytoplasm. So this is a melanocyte. You can see the nucleus is very large compared to the surrounding one. This is a malignant melanocyte. So this is a positive lymph node, but you need a microscope to detect that. There's other parameters that you provide. These are not used for staging, but are used, they have some correlation with prognosis, such as the mitotic rate. Presence of microsatellites actually is used in staging, so I take that back. Lymphovesic invasion, neurotropism, and so on. So there's additional parameters that they are put in a pathology report. And then the last role is to be a guidance of therapy. Can either predict the therapy or verify the response to therapy. To understand how you predict the therapy, we'll talk a little bit about how do we understand the melanomas arise and progress. So we think there is a precursor cell, which could be a melanocyte, one of those normal melanocytes you've seen. Your cells in your body, by chance, will undergo mutations. So it happens at a relatively high rate in all of us. Most of those mutations don't produce anything. The cell will basically die or not proliferate, but every now and then, there is one mutation that activates and makes the cell proliferate. So this is a hit, a genetic alteration, and will produce multiplications of these cells that all contains this hit. And this usually creates a nevus. So nevi have this one, nevi will have one of these, nevi can have BRAF mutation. What happens by chance, one of these cells can acquire another mutation, and that will produce a second wave of proliferation, creating like some sort of intermediate melanostic tumors, not quite melanoma, but in its way. And then there's additional alteration that will produce melanoma, okay? You can have this process going very fast. You don't necessarily have to see a nevus like it was discussed before. Only about, 20–40% are associated with a nevus. Or it can arise from a nevus without an intermediate tumor, so you can see the nevus associated. It's kind of rare to see all these three. But what's important to sort of realize is that these hits, these events, can be used to treat melanoma. So if you have a therapy that inhibits one of these, it will stop this sort of progression. It will stop the functioning of the melanoma cell. And the most important ones are the early ones. Like, for example, this first hit is one that drives the entire melanoma. So if you stop that from the melanoma cell, it potentially stops the melanoma from growing. And this is an outline of us. This is one single cell. This is the outside, the membrane. This is the nucleus. And this is one of the pathways that are normal in the cells that transmit a signal from the surface and make the cell proliferate. That happens all the time in normal cells. So you have these molecules that activate like a domino. So this gets activated by the molecule on top, and this term activates the molecule on the bottom, and so on until it gets to the nucleus. And you recognize some of these players here, like BRAF. So for example, let's say you have an alteration of BRAF that makes this molecule active all the time. it doesn't require an input from upstream. That will go to the nucleus and activate this entire cascade and make the cell proliferate. That's how, nevi appear, for example. That's why melanoma partly proliferate. So now if you have a drug that stops that in these melanocytes, then you're gonna stop proliferation. So that's very important to be able to know that the tumor has these events. So, luckily pathology can study the tissue, so you can look at the tissue and identify this broken system, these events, and then you can decide you can treat one of those. And we do this by looking at DNA and RNA. So DNA is this double helix that, as you know, stores all the information for the cell to function and to proliferate. And RNA is produced from the DNA, and from here you produce proteins that activate, that functions as machinery that make the cell work. And we look at this process called technology called next generation sequencing. I'm not going to go into details, but these are some of the machines we use that will tell you exactly what's broken in the cell. The other sort of arm of treatment pathology can help is verifying the effects of the treatment. And the most simple one is checking if the margins are free. So imagine this is a melanoma, and you do an excision around the melanoma. So you want to make sure that everything is out, but you don't actually, sometimes you don't see the extent of the melanoma with your naked eye. So the idea would be to be able to look at the normal tissue around the melanoma and make sure that's all normal tissue. You don't have melanoma touching the margin. And we do this by looking at, this is a section of that melanoma. This is the melanoma right here. This is the surface epidermis, and this is where the excision was made. We often ink it with a color so we can tell this is black. So you don't want to have melanoma touching here, because the rest of the tissue is left in the body. So then if you look at that, you can see, well, there are atypical cells. These are malignant melanocytes that touch the margin. So this margin is positive. That's going to be conveyed. So you need a larger excision here. There's going to be a second procedure to treat the disease. The second modality in which pathology can have an impact is looking at the effect of therapy. So this is a melanoma patient treated with an immunotherapy agent, which is pembrolizumab in this case. And you can see this used to be all melanoma, and now it's all necrotic. So this is melanoma that's dead, basically. So you can assess and say, okay, this patient had complete response, almost complete response, which is a good thing. But you need pathology to assess this. Otherwise, this will kind of look also like a mass forming if you look at imaging studies. One important portion that's not necessarily immediate important for treatment of patients, but for the future, is the ability of pathology to manage tissue for research and future testing. So as probably most of you know, if you're asked to give a consent, the tissue that's procured for the melanoma, which is going to be procured anyway because the tumor needs to be taken out, not all the tissue is used for diagnosis. So what's left can be preserved and used for future studies, future clinical trials. And usually in the pathology department, there is the infrastructure that gives them the ability to store this tissue so that it can be used in the future for various other research and to basically advance the science. One important thing aspect of pathology is the ability to give second opinions. All of these are the slides can be preserved indefinitely, so other people can look at them. And you ask, why would you need that? Well, the overwhelming majority of lesions we can diagnose by histology. So you can see at this whiter end, it's a nevus. At this more black one is melanoma. But life is not black and white. There's different shades of gray. So, less gray we think is a nevus, more black we think is melanoma. But what about the in-between? There's an in-between. And we want this to be as little as possible, but These are going to be the lesions that are borderline and maybe a furthest term, or very, very challenging to differentiate if it's a nevus or if it's melanoma. And in the best of worlds, these ones, we want to know what to do with them and maybe, classify some that probably these are benign, some probably malignant, but we cannot use conventional histology to do that for this small. So this is, this is where you can either have a second opinion. So there's people with a lot of expertise. Usually that the dermatopathology board has certification, like our team here, that you look at these lesions all the time. So you're better in differentiating benign from malignant. Most of the time they work in a team, so you can have multiple inputs, and obviously, more people, usually generate a better, better diagnosis than one person. But just know that differences in opinion in these lesions are not rare. So when that happens, most of the time, we try to do additional testing. So for a subset of this lesion, you need additional testing, usually looking at molecular events. So that's why I have like this DNA here. Usually I have molecular tests that look at the DNA. And why is that? So if you step back a little bit, melanoma is a malignant disease and has an unstable genetic material, which accumulates a lot of abnormal findings, whereas nevi shouldn't have that degree of abnormality. So if you look at the DNA, if you have some of these tests, fluorescence in situ hybridization, comparative genomic hybridization, they look at differences in the, you normally have 2 copies of each gene. So you have more than 2 copies or less than 2 copies, that's abnormal. You can also look at mutations of specific genes that can be associated, like third promoter is associated with melanoma. So just to show an example, this is a nevus and melanoma. You can recognize this as nevus as melanoma. And this is what's called comparative genomic hybridization for the nevus and for melanoma. You can see these are the chromosomes from the horizontal. This continuous lines means there's no alteration, there's 2 copies. And it doesn't take much to realize there's lots of alterations here, so up and down. It's not that complicated of a test to like interpret, basically to look at the number of abnormalities, but it's a nice distinction between like a nevus and melanoma. So in cases that are borderline, we use this to try to determine if the lesion, it's probably melanoma or it's likely to be a low-grade lesion or a nevus. So there this would be used if you have ambiguous lesions like this one. So I can't tell if this is a nevus or melanoma just based on histology. I run off this test. So if the test is negative, I favor a nevus. The test is positive, I favor melanoma. So that might be the reason sometimes you get additional testing when you try to diagnose the lesion. So what's the final product? Is the pathology report. That's how it looks. I mean, it has like few, if you ever read this, there's usually a patient identifier up here. Then you have a specimen identifier where the biopsy was taken from. The clinically, this is not for melanoma. So this, I see it has a rash on forearm. So it's for a biopsy for an inflammatory lesion. But for a melanoma, I'd probably say, pigmented lesion, give the characteristic of the lesion. There's a preoperative diagnosis, which is in this case an inflammatory disease. And then you have pathology diagnosis. So this is the main diagnosis, which is psoriasis from dermatitis. Obviously not cancer in this case. And usually there's an explanation of the diagnosis. A lot of the time the lingo here is a bit cryptic unless you're familiar with the, the medical terms. It's gonna be a bit difficult to understand. So it's often better, even if you get your hands on one of these, to have one of the professionals explain it to you. And anyway, at the bottom, these are additional tests. If one of the tests will be done, would be somewhere at the bottom here, like in this case, there was a test to identify if fungi are present. So it's put here and says negative. So I'm gonna end here to summarize what pathology does for melanoma diagnosis. So we mainly use either microscopy to look at this tissue at high magnification or genetic testing to either diagnose melanoma, stage it, identify the genetic alterations, or predict the response to treatment, or identify the response to treatment. All this is integrated in the management of a patient with melanoma. Well, thank you very much. I think we'll take questions at the end.